We're really excited. We're presenting our work today in the Presidential Symposium on our late-breaking abstract, which is looking at a randomized phase 3 study in transplant, the BMT-CTN-0901 study. And so this was a really important clinical trial performed between 2011 and 2014, which was really asking the question, the impact of conditioning intensity on clinical outcomes, important clinical outcomes. There's really, you can lump conditioning intensity into two big groups, myeloablation versus reduced intensity conditioning. And this was a study taking AML patients in remission and randomizing them to one of those two treatments. The study was actually stopped early because of an apparent advantage to the myeloablative conditioning arm and a very high relapse rate in AML patients in the reduced intensity arm. So what we're presenting here today is our follow-on analysis from that study, looking for measurable residual disease, and does that identify a high-risk group of patients in those getting reduced intensity conditioning. We took samples of 188 out of the 228 AML patients on this study from blood from prior to them getting a transplant. And we looked using ultra-deep next-generation sequencing to look for any trace of residual leukemia in the blood in these patients who were in a clinical remission. What we found was that we could actually identify two groups of patients. There's a group of patients where no variants were detected and a group of patients where there was variants detected. What's exciting is that actually identified risk groups based on conditioning. So if you had no variant detected, either a reduced intensity transplant or a myeloablative transplant resulted in similar overall survival. However, if you're in the group that had a variant detected prior to transplant in your blood that's associated with AML, despite being in a remission, those people who got myeloablative conditioning did much better than those who got reduced intensity. And there was a multivariate analysis, there was statistically significant association with very much increased relapse, worse disease-free survival, and worse overall survival for those with a genomic variant present in blood prior to transplant who went on to be randomized to reduced intensity. For me as a leukemia doctor, it's really exciting because there's some obvious next studies we can do. We've seemed to have identified a group of patients who seem to be a particularly high risk of getting reduced intensity transplant despite being in a remission. And so now we can think about trials where we really answer that question of what best to do for those patients. So I'm predominantly a laboratory investigator who sees leukemia patients clinically, but if I was a clinical trialist, I'd be very excited about the next generation of randomized trials to really try and answer the question of how we can do better for those people who are at highest risk.